Good afternoon, everyone. I am Evelyn Robles Rodriguez, Director of our Outreach, Prevention, and Survivorship Programs. I have the pleasure of being joined today for our Survivorship series by Dr. Tara Jennings, who is the Chief Resident of Dermatology at Cooper University Healthcare. She's entering her third year of residency and earned her undergraduate degree from Duke University and attended the Lewis Katz School of Medicine at Temple University. She is originally from right around our area in Allentown, PA, and she's going to speak to us today about sun safety and how to reduce your risk for skin cancer. Dr. Jennings, thank you so much for joining us today, and I leave it all on you now. Thank you.
Thank you for the introduction, Evelyn. So I'm so happy that you guys came to join me today for this talk. It's important information to know about, and we'll kind of go through a gamut of things. But like Evelyn said, there's a lot of opportunity at the end to ask specific questions. And I have my email on the last slide. I'm happy to answer any questions that you might have over email as well. So what is skin cancer? So really it's just the growth of abnormal cells in the top layer of our skin. We have all different types of skin cells, and the type of skin cancer depends on which cell is abnormal. And we'll kind of go through the main types of skin cancers. Out of all the cancers, skin cancer is the most common. And most skin cancers are very slow growing, easy to recognize, and very easily treated, which is why it's important that we kind of have a good way of recognizing them and we know how to prevent them. So we'll go through all of that during the talk today. So what causes skin cancer? Really, it's UV radiation. So it's the sun. And we get about 80% of our sun exposure from the time that we're 18. So a lot of the times people come into our office with the skin cancer, and they're, elderly, and they say, I never go out in the sun anymore. But really, it's an accumulation of your kind of like sun exposure over your life. And a lot of that happens when we're young. So it's nothing that you're doing wrong right now if you're protecting yourself from the sun, but it's a lifetime of exposure, really. And the ultraviolet radiation is important to know about because it's divided into 3 wavelength ranges that are important to just understand the concept. UVA is going to cause our long-term skin damage. It's what causes us to look aged. It's what causes wrinkling, and it can play a certain role in skin cancers, but UVB is the one that is really responsible for our skin cancers. B for bad is the way I think about it, and A for aging. So the UVB rays are what causes the direct damage to the skin. So damage to DNA causes our cells to kind of go awry and causes mutations to happen. And when mutations happen, they can be bad mutations, they can be good mutations, but the bad mutations can cause the cancer. So that one cell can turn into a cancer cell after damage and then start multiplying, which is what causes the cancer. UVC doesn't penetrate the atmosphere, so we don't need to worry about that. Some other things that cause skin cancer are just our genetics. There are certainly genetic syndromes that run in the family. That's why we always ask about a family history of skin cancer. And these genetic syndromes can be more than just skin cancer. It can be pancreatic cancer in a lot of cases as well. So it can come along with other cancers too. Certain chemicals can cause skin cancers. And then, of course, artificially produced UV radiation, so tanning bed use. So we always kind of ask about tanning bed history as well. So like I said, just to go over this concept one more time, our UVA rays are our aging rays, and our UVB rays are the bad rays, the ones that cause the damage to the skin and what causes the burns. A lot of times, and we'll go over this later when we talk about sunscreen, but when you hear broad spectrum sunscreen, that means that it covers both UVA and both UVB rays, which is very important. So you want to protect yourself from both UVA and UVB. Something really important that I don't think a lot of people recognize is that UVA rays can also come through glass. So when we're driving, those UVA rays can get through, which is, I think we see it all the time in clinic where people have um, a much more like kind of wrinkly face on just the left side from years of driving. So important to wear your sunscreen, even if you're just going to be in the car for that 15-minute commute in the morning and back. You can get UVA sun exposure. So who's at risk for getting skin cancer? We always say, I think a lot of people understand this concept, but it's the fair-skinned people with, red or blonde hair, lighter colored eyes, and skin that freckles and skin that burns easily. If you have a history of blistering sunburns in the past, that can lead you more at risk for getting skin cancer, and of course, tanning bed use. But I think that, the way that we think about, difference in skin color is that darker skin color types are more protected by the sun because they have more melanin. Melanin protects our skin from the damage from the sunlight. Fair-skinned individuals don't have as much melanin, so they're more disposed to being burnt and damaged by the sun. And it explains also why when we are out in the sun, why we get a tan. So that tan is just our body creating more melanin, the pigment, in order to prevent our skin from burning. So our fair-skinned folks really need to be careful out in the sun. They're definitely more at risk for getting skin cancer. But I would like to emphasize that any skin type can get skin cancer. So it's important for everyone to protect themselves from the sun because it really can happen in any individual. It just so happens that our fair-skinned folks are much more likely to get skin cancer. So the types of skin cancers, and we'll kind of go through this one by one, but a way to think about it is that there's two categories of skin cancers. There's the non-melanoma skin cancers, which are also called keratinocyte carcinomas. This includes our basal cell carcinomas and our squamous cell carcinomas for the most part. There's a ton of other skin cancers that kind of fall under this non-melanoma skin cancer category, but we won't talk about them today because they're, much more rare. And then the other category is melanoma. So if you have a general idea at the end of this talk of what a basal cell carcinoma, a squamous cell carcinoma, and a melanoma looks like, that's going to comprise about 99% of the skin cancers. So you'll be well informed. So basal cell carcinoma. This is by far and away the most common type of skin cancer. About 80% of all skin cancers are going to be basal cells. This is a malignant growth of cells from the bottom layer of the epidermis. It's the epidermis, our skin has multiple layers. The basal layer is the bottom. These are very, very slow growing. So when we catch these, it's great. But even if we don't for a long time, it will be okay. They generally do not spread to other parts of the body. What will happen is that they kind of just become larger over a small amount of times, and they can be locally destructive, but generally they are not going to go to other parts of the body or the lymph nodes. And they're typically only seen in body parts exposed to the sun. Here on the right is just different types of basal cell carcinomas, but in the next slide, I'll kind of go over how to spot it. So there's a superficial basal cell carcinoma. That just means a very early basal cell. So it kind of hasn't become a tumor quite yet. It's just kind of flush to the skin. It's going to be a pearly red patch that just doesn't seem to go away. A lot of people will come in and say that they like scratched themselves there. And then I'll say, how long has it been there though? And they'll be like, oh, about a year. But that doesn't make sense, right? If it was just a scratch, it should have kind of healed up. So if you see kind of like a flat red mark that kind of looks a little shiny on your skin, then that could represent a superficial basal cell. We typically see nodular basal cells a little bit more commonly. That's going to be the picture on the bottom. It's kind of a red raised up bump that is very pearly. It's shiny, and you can almost see the little tiny blood vessels in it that make it up. This again can bleed. So a big sign of a basal cell carcinoma is that like when you nick it, it starts to bleed. It's not going away. A good rule of thumb is that if you have something on your body that just doesn't seem to be healing or going away, it's good to get it checked out. We are going to see the basal cell carcinomas very, very commonly, usually from the upper lip and up. So anywhere on the forehead, the nose is a very common place, the lip is a very common place. But you can really find these anywhere where you have sun exposure, okay? A squamous cell carcinoma is our next most common type. It's about 20% of skin cancers. This is a malignant growth of squamous cells, so they make up the top part of the epidermis. These are also located on the face, but can occur anywhere. So they're going to be sun-exposed areas, but we can see them really, really anywhere. It's rare, but they can spread to the lymph nodes and other parts of the body. So this one, unlike a basal cell, we want to take a little bit more seriously in getting it treated and finding it quicker because it has the ability to spread to the lymph nodes and to other parts of the body more easily than basal cell carcinomas. And we'll kind of go through the same thing of what to look out for in the next slide. So our squamous cell carcinomas. So these are kind of going to be our scaly, red, non-healing bumps that can kind of have the crust overlying it a lot of the times. And a good telltale sign too, specifically for squamous cell carcinomas, is that they can be painful for the patient. So if you press on it, it will be a little bit painful. And they'll kind of have that just like that scaly looking raised up red bump that doesn't seem to be healing. It's another one of those where patients think that they scratched themselves or bumped themselves. But if it's not going away, it's important to take it. It's important to take care of it. The picture here on the bottom left that kind of looks like a little bump with like that central plug area, that's called a keratoacanthoma. It's a type of squamous cell carcinoma. This one, compared to other squamous cells, grows very, very quickly. So it's this bump that kind of seems like it's grown in the past 6 weeks. It's all of a sudden gotten so much bigger, and it has that central plug. So this is something good to know about because these can grow quite quickly, and it's easily spotted by the patients if they know what's going on with the keratoacanthoma. It's easy for them to spot it if they have had experience with it before. So squamous cell carcinomas, red kind of scaly, either patches or bumps that can also bleed and are painful. An actinic keratosis, some of you might have heard about this before, but I wanted to mention it because it's basically considered a precancer to squamous cell carcinomas. It's a red kind of scaly little patch typically on the face that when you rub your hands over it, it feels like sandpaper that just doesn't seem to be going away. About 5% of these, if they are left untreated, will progress to become squamous cell carcinomas, but they're very, very easily treated in the office. We just spray them with some liquid nitrogen and they are gone and we have nothing to worry about. This is also just secondary to long-term sun exposure. But if you guys know how to spot an actinic keratosis, then that will be great because we can catch it before it progresses to anything bad. And these are very, very, very common. We treat these all the time, and it's great when kind of patients can point them out to us and they say, I've had this sandpaper feeling spot on my face for a really long time and it won't go away. That's really helpful for us because sometimes you really do have to kind of feel over the area in order to be able to spot it and it's not as red. So you guys can really help us out there. So melanoma, we all have heard about melanoma. It's the most deadly form of skin cancer, and it can often spread to other parts of the body and quite quickly. It's much, much less common than a squamous cell or a basal cell. It's really about, less than 5%. and this can run in families. So if you have an immediate family member, meaning a parent or a sibling or a grandparent that has a history of melanoma, you should be getting yearly skin checks because they can run in the family, as we mentioned before. Just to point this out, and we'll talk about how to spot melanomas, but on this picture, you can kind of see the much darker spot on this gentleman's back. Whenever you see a spot on your body that doesn't look like your other spots, and you say, this just looks funny compared to everything else, we call that the ugly duckling sign. So that means it's just, sometimes your moles can look funny individually, but you'll have other moles that look just like it. That's very reassuring to us because some people can just have funky looking moles, and that's the type of moles that they make. But when you make a mole that doesn't look like your other ones, that should raise a red flag and perk your ears up, and you let us know as soon as you see that, okay? So how to spot a melanoma. We just talked about the ugly duckling sign. These are typically very darkly pigmented. This is nothing for you guys to worry about, but just so you know, they can be amelanonic, meaning that they're not pigmented. Usually in lighter skin individuals are red hair, blue-eyed individuals. They'll have irregular borders. They can have different colors within the lesion. They're typically asymmetric and they change over time. And this rule is called the melanoma ABCDE rule. So we'll go over each one of these in details to help you be able to spot out a melanoma if you can just remember this rule. So like I said, A for asymmetry, B for borders, C for color, D for diameter, and E for evolution, and we'll go through each one of them. So A for asymmetry. So if you have a mole on your body that you've had for forever, it will a lot of them that are benign will look like the picture that's furthest on the left here. Very symmetrical. You can kind of cut it in half and fold it over, and it will be perfectly symmetrical to the other one. An asymmetrical one, you'll cut in half and one side will look completely different than the other. As you can see on this picture on the right, this lesion looks completely different on the left than on the right. That's an important thing to kind of notice and should also be a red flag for you. So A for asymmetry. B for borders. Our benign moles have a very kind of smooth border that you can almost draw around very easily with a circle. Our melanoma is going to have very irregular borders, meaning they're jagged. They're just not smooth at all. They're very irregular. And this is a great example on the left. This is also a great example of asymmetry, right? The left looks completely different from the right. C for color. So our benign moles will have a very uniform color typically, and it's okay to have a little bit of variation, but our melanomas are going to typically have, 1 to 3, usually 2 to 3 colors in them. So this picture on the left of a melanoma has red, brown, and a little bit of even blue if you look closely. So that's something that's definitely a red flag when there's multiple colors. So color variation is a big key. D for diameter. This one's not used as much in our literature anymore because we can, there's certainly moles that are bigger than 6 millimeters or the end of a pencil tip. But I think that if you notice something that has some of the other characteristics that we've talked about, asymmetry, borders, or color, and it's kind of bigger than 6 millimeters, then that's kind of even more evidence that it should be something you're worried about. E for evolution. This one is by far and away the most important one, I think. So if you have a mole that seems to be changing from the way that it's looked before, then that's generally something that you should let us know about. Regular moles can become irritated and can become red and kind of painful, but if they're growing in size or they're starting to bleed, they're changing in some type of way, then that's something that you should let us know about. A lot of the time, like I said, it will just be like a regular irritated mole that's nothing to worry about, and we can kind of just take off just to help you guys. But I think that a changing mole is something that's important to kind of note. what I always tell my patients is I say, if you're even slightly worried about a mole on your body, take a picture of it in your phone and mark the date on it, and then go back in about 4 weeks just to see if it's changed at all. You can also measure it. I always recommend measuring it if you have a tape measure around. So measuring it, seeing how many millimeters it is, and taking a picture can really help us, and it can help you. You can say it grew 2 millimeters in the last 4 weeks. And then here's the picture of what it looked like 4 weeks ago. And we can compare it to what we see today. And that can be super, super helpful for us. Let's see. So we went through all of the ABCDE rule and then the types of skin cancers. And I always like to just kind of give an overview of the skin cancer treatment. Like I said before, skin cancer is luckily fairly easy to treat. We have a lot of different modalities that we can treat it with, and it all depends on the patient and how aggressive they want to be. Everything is usually able to be removed completely with margins. And it's kind of like if we catch it early enough, we just excise it and you don't have to think about it again. You'll get skin checks. And they can even sometimes be, we can even use topical creams these days. They're coming up with new medications all the time. And especially for our elderly folks that might not feel like they want to go through a surgery to get everything out, we have some topical medications that we can kind of use that are also efficacious. Obviously not as good as surgery, but we have to consider the circumstances for our patients and do what's best for them. If Generally, if a skin cancer is found on the face, the hands, or the feet, we recommend something called Mohs micrographic surgery. That can be seen here on the lower screen, where we kind of take what we see clinically around the lesion. So we look in our microscopes and we'll cut around where we see the cancer is. We then take it back. We look under the microscope to see if there's any cancer cells left. And if we do see cancer cells, then we'll go back and we'll take more just in that one spot. Generally there can, it can be 1 to 2 levels is what we call it, hopefully, but sometimes we have to keep going all day, but we do make sure that everything is out by the end of the surgery. And then if it's on the body, we generally recommend something just called a wide local excision, where we mark around where the cancer is, and then we take specific margins of normal skin to make sure that we have all the cancer out. I wanted to show you these pictures, the picture on the bottom right, not to scare you, but to let you know that, when patients let their skin cancer go, especially on their face, what looks like a small cancer can kind of end up spreading pretty far under the skin from what, we can see under the microscope, but what you can't see. So a lot of times patients will be like, oh, my cancer was just this big. And then they come in for surgery, but really it kind of has legs under the skin that you can't see, that we can only see under the microscope. So just the earlier that you can get in, the better. You should never be afraid to kind of call up the dermatologist and say that you're worried about a spot, because the earlier that you can get in, the better. I wanted to mention seborrheic keratoses just really quickly, because we get patients that come in all the time very, very worried that these spots are melanomas, and deservedly so. They can be very easily confused with a melanoma. But these are very, very, very common lesions that, we all probably have here somewhere on our body. Some patients have a lot more than others. But just to differentiate it from a melanoma, it's kind of that like waxy, stuck on papule that you almost feel like you can peel off. That when you see a melanoma, you kind of can see that it's kind of growing deep. With the seborrheic keratoses, you can see that it's kind of almost just stuck onto the skin like a sticker. But they can look like melanomas because they can be different colors. They're darkly pigmented. And we get people that come in all the time worried that they are. But I just wanted to give some reassurance that there are these entities called seborrheic keratoses. They're very, very common and nothing to worry about. So how do we prevent skin cancer. As we talked about before, protecting yourself from the sun is by far and away the most important thing that you can do. And we'll talk about all of these things. So we'll talk about sunscreen and sun protective clothing and what times of the day to avoid the sunlight. And like I said before, 80% of our lifetime sun exposure occurs by the age of 18. So unfortunately for a lot of us, the damage has already been done, and now it's just about preventing further damage to the skin. So sunscreen, this is a hot topic that we get asked about all the time, and I will certainly give my opinions on it, but there's a lot of opinions out there, and mine isn't necessarily the right opinion, but I will give you my opinion. So sunscreen can be kind of branched into two different categories. There's mineral sunscreen and there's chemical sunscreen. Mineral sunscreens are a physical barrier to the sunlight. So if you look at the diagram on the left, it basically is a zinc oxide or a titanium oxide that essentially reflects the sun. They act like a shield. Chemical sunscreen, on the other hand, do not create a physical barrier. They absorb the UV light kind of like a sponge before it can create any damage. So they're two very different mechanisms, and they both work very well. Okay. The things to consider about chemical sunscreens compared to physical is that they're not always broad spectrum. If you'll see a list of chemicals on the sunscreens, and some of them only protect against UVB, some of them only protect against UVA. So there's a lot of chemical sunscreens out there that only protect against UVB, but you should protect against UVA too. So like I said, if you're getting a chemical sunscreen, make sure it says broad spectrum over it, okay? The other thing about chemical sunscreen is that it can cause a lot of skin irritation. There's a chemical called oxybenzone in chemical sunscreens that was a very, very common contact allergen. It was like the contact allergen of the year a couple, I think 2 or 3 years ago. So a lot of times people can develop rashes after using sunscreen. And that's typically the one that causes the problems. And then I think that a lot of us have heard about the controversy with marine life. There are certain chemicals, especially the PABAs, that can cause damage to our coral reef and other marine species. So if you're worried about that, then a mineral sunscreen won't be anything to worry about. And then I just wanted to touch on what SPF is. So I think we've all heard SPF before, and we look for it in our sunscreens. But just so that you're aware, SPF is a measure of how much solar energy, or that UV radiation, is required to produce a sunburn on protected skin relative to the amount of solar energy required to produce a sunburn on unprotected skin. So if it's an SPF 30, you basically need 30 times more solar lighter energy in order to cause a burn compared to unprotected skin. As the SPF increases, the sunburn protection increases. There's a lot of misconception in the literature and around that SPF relates to time of exposure. So some people thought that, if you normally burn after just 1 hour and then you put an SPF of 15 on, then that meant that you won't burn for 15 hours. And that's not true. It's not directly related to the time of solar exposure, but the amount of exposure. So for example, the following exposures may result in the same amount of energy. So 1 hour at 9 a.m. in the morning versus just 15 minutes at 1 p.m. So it's just the amount of energy that you're getting. Generally, and I'll go over this again, an SPF of 30 is what's needed for really good protection, 30 or above. If you're below that, then there's, it's better than nothing, but you're not getting too much protection. So my guidelines for sunscreen use, like I said, an SPF of 30 or greater. It's broad spectrum, so it's covering that UVA and UVB spectrum. So you're protecting against burns, but you're also protecting against aging. I always like to say apply at least every 2 hours, and even more often if you're sweating a lot, if you're going in the water. And then the other thing is that any sunscreen is better than none. So if you're the type of person that will only put on sunscreen if it's in a spray bottle and the chemical one is what you have, that is fine. There's nothing wrong with the chemical sunscreen except for what we talked about before. But if you're going to be more likely to use it in a spray bottle, then go for it. Any sunscreen is better than none. And then always sun protection, with umbrellas, sunglasses, hats should always be used in conjunction with sunscreen. If we can protect ourselves from the sun with clothing or just prevent that sun from reaching our skin at all, then that's the best. Our second line should be sunscreen. Our first line should be our sun protection with our umbrellas, hats, and so on and so forth. So these are my favorite sunscreens. I really like mineral sunscreen. That's my personal preference because I feel like it protects my skin a little bit better. I also have a condition called melasma where my skin hyperpigments and that's a little bit better for it. But I like the Ultra Sport one that you see the banana boat there. It's a cheaper one that's a chemical sunscreen that comes in packs and a spray. And I feel like I use that one at the beach because it's water resistant too. But any of these are going to be great. They are all broad spectrum, and they are all over an SPF of 30. I will point out I really like these Neutrogena. They look like deodorant sticks, kind of. I have that in my purse, and I put it on my face all the time. It's basically like a stick that you can just put on your face. So I always have that with me. It's really small. I don't have to get my hands all sticky or anything from the sunscreen. It's just a stick that I can put on my face. So these ones are my favorites. And then this is just a chart that I really like. So different time, like I mentioned before, different times of the day, you're going to get different amounts of sun exposure. So after 10 a.m. kind of to 2 p.m. is typically when you're getting the most sun and the strongest sun. You can always go online and look at what the UV rating is, which is basically how strong the sun is. And this is a chart that I really like about the protection that you should be using based on the UV rating. So if it's a low one, we always are going to recommend to wear the protective clothing and the sunscreen. But if you get between, once you get into like above 6, you should be kind of seeking shade and be under an umbrella at that time, because even if you wear all the sunscreen in the world, you're still gonna kind of get that sun, the sun damage. Sun protective clothing, like we talked about before. So wearing tight knit clothes. So something that I like to just give as a reference is that a cotton t-shirt only has an SPF, a white cotton t-shirt only has an SPF of 4. So if you kind of hold it up to the sun and you can see through it, it's basically like you're wearing nothing. It's offering very little protection. If you wear tighter knit clothes, that when you hold it up to the sun, you can't really see through it, that's a good protective. That's the kind of the way that I like to think about it. Always wearing hats and sunglasses is recommended. And then there's lots of different brands out there right now that basically have SPF embedded in the clothes, so it just offers a little bit more protection, especially for the fair-skinned individuals. I always recommend this. The company that I like best is called Coolie Bar, and they have really it's for men and women. They have fashionable women's clothes. They have really great wide brim hats that have SPF in it. And I really like a lot of their stuff. We in our office, if you come by, or if you happen to have an appointment with us, we have 20% off coupons in our office that we would be able to give you. But I really like this, and I think it's great, especially if you are a beach goer. Then having a hat or a sun dress that has some SPF in it can be really nice to have. So other supplements. So we talk about these with our patients. They're not necessary, but I just wanted to inform you that they are out there. There's something called HelioCare, which is essentially a dietary supplement. It's a plant protein that they've showed in studies that actually helps protect itself, protect against the sun. I describe it as an internal sunscreen. I think especially if you've had skin cancers in the past, this is something that might be worth, at least taking when you're on sunny vacations or if you're going to the beach. You should start taking it about 2 days beforehand and then use it all the way through your vacation. And it doesn't cause any problems. Like I've never heard anyone complain that it causes stomach upset or anything like that. You can get these over the counter or online. Also, niacinamide is vitamin B3. They've shown really, really excellent results in studies that this protects against specifically squamous cell carcinomas and actinic keratoses, just by taking it twice a day. So, I mean, I myself take this twice a day just to protect myself. There's just the evidence is really, really wonderful for this vitamin in particular in decreasing the amount of actinic keratoses and squamous cell carcinomas in patients that kind of tend to get them. So I always recommend it, especially to patients that have had multiple skin cancers in the past. So, who should see a dermatologist? We get this question all the time. If you have a personal history of skin cancer, you should definitely be seeing us at least once a year. If you have a recent diagnosis of melanoma, we like to see every 3 months, typically for the first 1 to 2 years. If it's a non-melanoma skin cancer, a basal cell or a squamous cell, then every 3 to 6 months for the first 2 years, depending on which dermatologist you see. Anyone with a family history of skin cancer in their parents, siblings, or grandparents should at least just come and get screened if they haven't before. If there's nothing to worry about and your dermatologist says that you don't have a lot of moles, you're not very fair-skinned, they'll usually say to come back in, 5 years or something like that. But you should at least get screened once by a dermatologist if you have a family history of skin cancer. And then, like I said before, what I hope you've learned from this talk is that you should seek a dermatologist if you notice anything on your body that's growing, changing in color or size and bleeding or non-healing. Anything that kind of doesn't seem to be, healing up in the way that any other, kind of scrape or bump would, then that should be a red flag that this could be a cancer, okay? So I hope, let me see, I think that is it. I hope that you got some valuable information from this talk, and I'm certainly open to any questions if anyone has any.
Thanks, Dr. Jennings. That was an excellent overview of skin cancer, as well as some really great tips for not only keeping safe in the sun, but ways to lower your risk of future skin cancers.